You can't replace part of the brain. Like, you
treat them the same.
The source of truth for the medtech industry.
Coexists with the province.
Robot understands things automatically.
Number one show in the medtech industry.
So Stryker got ahead of that and changed in the 90s, built $1 billion company that held up high, a lot of things.
State of MedTech with your host, Omar and Khateeb.
Everybody, welcome back to the show. We're joined by a guest, somebody who I've been wanting to have on the show for some time now as I've followed him and his content over the years, and that's Dr. Tim Deer, who's the chairman of the American Society of Pain and Neuroscience. And for this episode, I'm really excited just because, spine and pain management is a very exciting space. There's always a lot of innovation. One of the specialties that, again, I love all the specialties, but when I go to the spine and pain conferences, it's always exciting because there's such cool tech there. So we're going to talk about all that and more. Dr. Deer, thank you so much for coming on the show. How are you doing?
Omar, I'm doing fantastic. Thank you. It's great to be here with you. I certainly have been watching your show recently, and it's certainly an honor to be here.
Absolutely. Absolutely. And, for some of our listeners who are not so familiar and maybe not in the spine and pain management world, can you give us like a little quick, 1 minute intro to who you are, your background? I mean, what I was most excited about is that you're not only a clinician, but you're actively involved in industry, you're an entrepreneur. And so if you can kind of give a little bit of a background yourself, that'd be great.
Yeah, I'm an anesthesiologist by training. I haven't done anesthesiology since 1996, so it's been quite a while. Really fortunate to be in the early days of interventional spine and in neuromodulation. So my career has been really about partnering with other people, whether it be locally with other physicians, whether it be nationally with engineers and tech experts, leadership in different companies to develop products or do FDA level 1 studies or to bring really new things to patients along the way. And then the other part of my career has been really working on the creation and the work in societies. And I've been involved in leadership of several societies over the years. And currently I'm chairman, as you mentioned earlier, of ASPEN, the American Society of Pain and Neuroscience. So it's been my goal to use that to mentor people to make our fields better. So that's a snapshot. You said about a minute. That kind of gives a overall broad stroke of kind of what I've done in the field and what we're continuing to do with the help of many people as we have a great team of people we work with both locally and nationally.
Fantastic. Yeah. And by the way, I've heard so many great things about Aspen. I'll leave in the show notes info on that for our listeners. So let's start out with kind of the state of things, like in the terms of the state of interventional spine and pain. There's a whole lot that's gone on. What are some things that kind of come top of mind where you're most excited about as a clinician?
Well, I think it's really been exciting. So when I started in this field many years ago, we really thought that spinal cord stimulation was about as advanced as we would ever get. And we're still doing that. We're doing spinal cord stimulation. It's evolved, as you probably know, over the last 30 years with new waveforms and new devices and new technologies. But now we also have really worked on great methods along with our neurosurgeon and orthopedic surgeon colleagues to make things less invasive in the spine, to do less invasive things like basivertebral nerve ablation, posterior lateral fusions of the spine, to go in and do things to secure the SI joint. So we've really done a lot of things that we really have seen a kind of almost a collaboration where we've come closer together, where we're doing more invasive things, but staying minimally invasive. The surgeons that we work with are kind of helping us in that kind of progression. And then the other thing you asked about what we're excited about, I think we're getting excited about really looking at big data to pick the right patients. We're doing more and more of that now. So, we go back, I've worked with a lot of different big data experts, and can we decide who would be the best person for a different device? We're doing that. In the same time, we're looking at things like biomarkers to also make patient selection better. So if you combine all those things along with AI, I think what we're going to see in the next 10 years of evolution of our field is improvement in selection. So we've seen a progression of technology, a progression of minimally invasive spine. Product development has continued to evolve with a lot of investment, as you know, Omar. I know you work with a lot of those companies as well. But we're also seeing a refinement of who may be the best candidate for things. And I think that's where we're going to go in the next decade, is that refinement is going to make outcomes so much better.
So can you give us a little bit of background on that when it comes to the refinement and patient selection? We both know it's so important when it comes to selecting your patient. It's not really a catch-all as it used to be, let's say 2 or 3 decades ago. But what did that used to look like in the past, and what is it moving towards today?
Well, it's slowly evolving, and it's local. And some of that selection right now is a local process. And what I mean by that, if you come to our center, and you see one of the orthopedic surgeons, a neurosurgeon we work closely with, and you had a 81-year-old with grade 1 spondylolisthesis and stenosis, pulmonary artery disease, pulmonary hypertension, and all these risk factors, our surgeon would say, get on the phone, hey, Dr. Deere, let's talk. We'll say this person will be a better candidate for something I might do minimally. Whereas if I see a patient with severe grade 2 spondylolisthesis who is, 60 years old and healthy, I'm going to get on the phone and ask my surgeon to see them for possible open fusion, which may be what they really need. And it's that collaboration now. So that's really changed, because 10 years ago, and still, unfortunately, in some parts of the country today, whoever you saw is what you got or what you get. And that's really not proper. We should work together to really stratify patients, create algorithms. That's what we do at Aspen. We try to write best practice papers to create the algorithm to help us make decisions based on what we know. Now, that gets more refined when we go back and look at big data. Let's say we have 5,000 people who have a certain procedure. Can I tell you who did the best with that based on the big data over time? Because we all can have our biases and say what we want, but big data doesn't lie very much. It lies a little bit sometimes based on how you analyze it, but it doesn't lie very much. So I do think that's going to be the second part of that refinement. Local decision-making based on ethics and based on what we know about patients, algorithms, big data confirmation of what we think, and then the next stage then will be the biomarkers and things we can look for. So that's further development. And then lastly, you tie AI back into that process as we get more advanced. And it tells us, hey, Tim, based on this factor and this big data and this person's health habits, and based on their MRI and based on their x-rays, they should have this. And I think that's what we're going to see. And that's a lot, Omar. It's a lot for me to even say, but that's really where we're going. And we're going there very, very quickly. I think when you come to Aspen in July in Miami, you're going to see this on the podium right now starting to happen.
Fantastic. I want to dig into that a little bit. One of the things that we're starting to see, I think what's exciting about AI is that, it's kind of that buzzword, went through the hype cycle of innovation, over the last 5 or 10 years. I think at some point, like the running joke with startups was when you're raising money, you call it AI, but when you're actually hiring people, you call it ML. But now with ChatGPT, it's starting to enter like daily use within the public, right? Which is exciting. And at least when we've seen like ChatGPT, Microsoft and Google and those other AI models, the reality is that the value of them actually comes down to the training data that you have. So it's almost like the algorithms aren't the most valuable thing. It's the training data you have below that. So when it comes to these, for some of the algorithms that you guys use at Aspen and others, like how do you think about sourcing the training data? Who should technically own that? Where does the central hub of that fit? Because one of the problems we see in healthcare is that it's so fragmented. I mean, look at how EMRs are managed in hospitals. How do we sort through that and make sure that we set up the right databases to start training those models?
Well, so that's a great question. I will say the most abused term right now, the last 3 years, has been AI. And what I mean by that is companies have called themselves AI when there's been no AI component of what they're doing at all. And they've been doing algorithms that have nothing to do with the patient specifically and calling that AI. And I've seen 3 different companies do that are fairly large companies. And, when I talk to fellows, the fellows are fooled by it. They'll say, oh, did you see the AI? And I said, no, I saw no AI there. So I do think that we right now in 2024, we don't have AI very heavily involved in either neuromodulation or minimally invasive spine. We just don't. We're writing a best practice on it right now, led by Dr. Latif and Dr. Massey. But I don't think right now we're not even in the first quarter yet. We're in the pregame in our field. So I don't think I can say anything that's done for us yet at all. But as I talk to engineers and software engineers and people that are collaborating with people like Google and Apple, what I'm seeing is the future. And I am seeing what they're integrating that's going to be coming very soon to each of those areas that will be true AI. So I do think that in our field, it's been an abused term. It's not been valuable yet. But the reason as I went through that long litany of when you asked me what's going to happen, the reason I put AI last is because that's what's going to tie everything together. But we are not there yet. We're not even close. But that's going to evolve so quickly that if you and I are talking in 2 or 3 years, Omar, we're going to say, man, that was quick. because it's going to happen. And it's going to happen. It's going to be very good for those who know how to use it properly. Who owns the data is going to be the question. So, and again, that's going to be really critical. For example, and I'll give you 2 or 3 examples here. If we think about monitoring of neuromodulation devices. So I put a device in you, you go home. And so I have the company who made the device monitoring you. They're sending it to a cloud to my EHR, which is owned by a hospital. I have the patient chart, which I may have in a private practice, may own. So we all 3 have data. The payer wants the data. They want to know how the patient's doing. They have the data. Who owns that data? That's going to be a great question, because the data will determine how we can analyze it to learn those things about training and things of that nature. So that's going to be more and more important is who owns the data. And like, for example, now there's several companies I've given advice to, some of which are very good companies that can go in with the outcomes tools for your practice on a little iPad and collect data on every patient you have. And so now you have 50,000 patients with data. Well, do you own that? Does Cigna and Aetna and Medicare own that? Who owns the data on that patient? So I do think that will have to be determined. And I don't think it's determined yet in most scenarios. And there's going to have to be both discussion, there's going to be legal issues around who owns the data. And the data is very valuable, as you know. So it could really mean a lot of financial issues for people based on who has that data.
Let me feel free to hard pass on this one, but who comes to mind when I ask you this question? Who should not own that data?
I don't know the answer to that, because I think data is power. So I think it depends on how it's used, right? So right now I have patients all the time. I'll give you an example of why I say that. We have patients all the time that need a procedure, AMA approved, has a CPT code. So by definition, it's no longer experimental. It has a CPT code, right? And we know based on studies it's successful, and we start getting data on Medicare patients. We know it's working. We have data in our own practices. Yes, it's really helping people. And then we'll have an insurance company who say, oh, it's experimental, we're not going to approve it, even though they may already know based on the other data it works. And we see it as a delay technique. So the reason I bring that point up, Omar, is that if people use anything incorrectly to hurt patients, it's going to really limit access, not improve access. So I would just say that whoever owns the data should be transparent, so we can look at it. Because what I don't want to have happen is someone owning data and saying, Mr. Jones shouldn't have this procedure because it doesn't work, but they won't show us the data that's proved that, for example. Or on the other hand, I may have data that says it doesn't work, but I want to get reimbursed for it. So I say it does, and I won't show you my data. I'd like to see a transparent data pool where we all can see the same data. Because if something works really well, it should be paid for. If something doesn't work very well, we shouldn't do it. And so to me, transparency would answer your question. I think everyone should have the data, but if someone lies about the data, we should be able to call each other out on that, whether it be an insurance company, a doctor, a device company, whatever it may be.
I think it's a great point. I love the way you're thinking around that. For a lot of the investors who listen to the show, and I'm sure many are going to listen to this, if you look at the, let's say continuum of care when it comes to interventional spine and pain management, you have, let's say, the diagnosis phase, right? The intervention phase, and then we can call it, let's say, the monitoring phase, which is post-op. Of those 3 areas, where do you feel like you have most of the blue ocean areas where there's an opportunity for a lot of innovation and disruption to happen?
Well, so I think it's one of the best areas right now, and I think everyone's proven it based on their investments. Right? We're seeing every week we see somebody investing millions of dollars in a startup company, which a lot of those companies I have the opportunity to work with. So I'd love to see the investment. But I don't know if you have any, I think I know you have one toddler there. When you have small kids playing soccer when they're 3 or 4 years old, they all chase around the ball and they're going different directions and they don't know what they're doing. Right now, that's where we are. So you asked a great question. So the diagnosis phase, you have family of physicians, you have primary care specialists, you have physiatrists, you have anesthesiologists, you have surgeons, you have, chiropractors, you have all these people making diagnoses. And many times there's not a diagnosis that is really very solid because there isn't the criteria for the diagnoses. And then you get to the treatment phase. Well, it depends on who you see. If you see this person, you may get chiropractic care. You may get opioids from this person over here, which we've played that game before. It didn't work out very well. So I'm very opposed to that in most of these patients. Then we have interventions, people like myself, where we do minimally invasive spine work. And then you have a surgeon who may do a large surgery that maybe wasn't needed, but it may have been needed. And we have to then figure that out. So So yes, where the blue ocean is, it's in the diagnosis. And a good example of that is SI joint pain. We know that you have to do certain things on examination. You have to do 2 intra-joint injections with contrast. We know you have to respond to that in a certain way. So if you do all those things, we've found in our practice, for example, based on our data, we get great outcomes in that population. We don't skip a step though. We make the diagnosis based on the criteria. We don't have that for most things, right? We don't have all of those steps. It's mostly based on the MRI only or the patient's symptoms only. And so there's a lot of room for diagnoses. And I think that's going to be evolving. And that is where AI is going to play a role, for example. For diagnostic radiology, AI is going to be really, I think, tremendously a good asset for us. Then we have a lot of blue ocean and minimally invasive procedures before you get to the large surgeries. We have no surgery and medication management, and we have big surgeries. In between there is where we're going to go. And that's where the biggest ocean is, if you will. The reason for that is, and I see it every day in my career. Today I saw quite a few people in my office. No one wants a bigger surgery. Most people don't, if they can avoid it. No one wants to spend the night in the hospital if they don't have to. No one wants to be, debilitated in their ability to walk for 6 weeks if they don't have to be. No one wants to take more risks than they need. So every patient wants to have something smaller done if they can get a good outcome. That's why data has to support it. And the biggest blue ocean right now is in research and development of those methods. And because those who have data will win. Those who have evidence will win. And I think the days where someone could come to market with a 510K and not do a study is going to go away. And I'm glad for that, because we've seen a few companies now that did that and didn't make it in our field. And they didn't make it because I think we're starting to expect data and level 1 evidence. And if you don't have either one of those, we expect some form of registry to follow prospectively how people do. We expect some accountability of your outcomes. So that I think the company that does minimally invasive things and make things less expensive, less invasive, who then back that up with high level data or registries is the future. And that's where I think all investors should look at most closely right now.
When you mentioned that, by the way, I completely agree. I think this ended. Maybe it started to die off over the last 10 years, but nowadays, I think the good old days of hey, you have a great idea, get a 510K, take it to market, and then within 6 months, somebody will buy you out. I think those days are gone. Even the IPO market these days, we haven't had a medtech IPO. I think that we've only had one since 2021, right? And that's, I think, a good indication that the markets are demanding a lot more rigor for these things. That being said, with the current players that are out there in the pain and spine world, what are some companies that kind of come to mind that did it the right way that you would say that's kind of a good model to kind of exemplify after?
Well, first of all, I want to say right now, I think we have maybe 10 companies, which I'm not going to name at the moment, who are great candidates for either IPO or mergers and acquisitions. And the market dynamics has been unfavorable the last 3 years, which has held all that back. So I'm hoping we get through this next election and we see things calm down either way, and we see that improve, because that has been unfortunate, because so much hard work goes. And there's a point, Omar, as you know, if you raise too much money, at some point you can't really go to merger and acquisition anymore. You have to go to IPO, and it becomes very difficult. So I am unhappy with the conditions of the market the last 3 years. It's been very, very bad. So I want to start off by saying that. I'll name a few companies I think that did it the right way. I mean, I think recently we saw 2 acquisitions, that I'm very good friends with one group of those folks and involved in the other. One was Relieve It, and their acquisition by Boston Scientific. I think that was phenomenal. One of the best acquisitions in this pain space in a long time. I do that procedure, BVN. If you go on my website, you'll see one of the patients that's featured nationally that had that done in our clinic, one of our first patients, and how well he's done. But the way they did that was, it took 10 years. So you said, who did it correctly? Well, it took 10 years. So even a company that did it correctly, it's not easy. And then eventually they make an exit. And I think that was a great collaboration so far. Now the proof's in the pudding and how it's done now after the acquisition, because we've seen that go both ways in the past with different companies. Axonics is the other company I think has done it phenomenally well. And again, I had the honor of being involved in the beginning of Axonics with Ray Cohen and his team, and was an advisor for several years and still a good friend to the company. And we took a device, and the Axonics device, we thought there was an unmet need. Medtronic was the only player in the sacral nerve stimulation world at the time. And we also felt there was a room for improvement in technology, and there was a reimbursement route, and there was a room for better engineering to improve things, in my opinion. That's an opinion, not necessarily a fact. But what that led to was a company called Axonics that then grew and really found physician partners who thought it was a great opportunity for them. I don't do that procedure, so I was involved in the development of the device and then the rollout to physician education. But I think they did it very well. And as you know, they also exited to Boston Scientific recently, waiting on the FTC approval for that acquisition. So those are two examples of things I think were phenomenal execution by the leadership of those companies, and partnering the right way with physicians to get the right data and the right evidence and the right clinical outcomes in the real world that led to great acquisition. So I hope we see more of that. I think we most likely will, but I do think that the environment has been very, very difficult. So I hope that improves. For all our investors on the line, let's get together with the banks and the venture capitalists and the markets and get this thing turned around so we can see some exits here.
No, I completely agree. And I'm kind of hoping for that this coming election cycle that we kind of get back to the way things were, because it's been a tough 3 years. I think Jonathan Norris of HSBC him and his team put out this great report that showed, across the board, health tech, med tech, biotech, pharma, that investments were down last year anywhere between like 17 and 26%. So, and when I see that, like the first thing I think of, I'm like, man, like a lot of patients are going to suffer as a result of that. So hopefully we get back to those days. Doctor, I don't mean to put you on the spot here, but there's something that I've been fascinated by, and I don't know what to make of it. I wanted to ask you about it. Is that, I think in the last like 5-10 years, especially the last 5 years, because of patient demand and interest, you've seen certain procedures that used to be exclusively done by spine surgeons. Now there's sort of thanks to technology and innovation, sort of a choice, where pain management physicians can do it or spine. It feels like at some point there's a lot of debates happening on LinkedIn, like SI joint fusion is one area. Can you kind of dive into that for the listeners? Because I've had some listeners ask me about that, and part of me, this is one of the reasons why I wanted to have you on. It was like, I'm not an expert in that, so I was like, I'd rather have somebody who actually lives and breathes that world. What do you take of that like situation, and what can we understand from it?
Well, I'm going to give you a great question. I get this question often, and I'm involved in these discussions often. So I'm going to start with 3 scenarios. One scenario, there's interventional spine pain, mostly anesthesiology, physiology based. Then there's interventional radiology, and we're kind of in the same boat over on this side. Then there's ortho, spine, and neurosurgery over on this side. And when I first started practicing, this is an interesting tidbit that most of your listeners probably don't know. Neurosurgeons in my town and nationally weren't allowed to do a spinal fusion without an orthopedic surgeon, because the orthopedic surgeon,
I never knew that.
Yeah, they didn't feel they were qualified to do a pedicle screw. So if a neurosurgeon wanted to book a fusion, he or she had to go in the OR with the ortho spine surgeon. But remember, most ortho spine surgeons in those days had not done a spine fellowship. All orthopedic surgeons were doing spine. So when I came to West Virginia in the mid '90s, it was kind of a zoo out there, and people were doing all kind of fusions and all kind of people. And even though they were good surgeons with good intention, a lot of those people failed, and that's why I got so busy so quickly, because it was patient selection, and technology at the time. So so we have that history behind us. So we know that pain physicians are not all the same. And so if you have a training and a fellowship program where you get a lot of hands-on work, whether it be interventional radiology, interventional spine and pain, whatever it may be, then you'll come out of your fellowship ready with this tool set to really expand your field. And most of us, whether you got trained 2 years ago or 10 years ago or 20 years ago, or you're a neurosurgeon who did a 7-year residency at UVA, where I trained in anesthesiology and pain, you're going to see new procedures you didn't learn, right? So that's just going to happen for all of us. There has to be a method for that. But when you come out with the basic skills, what pain people are really good at is the interpretation and use of fluoroscopy and putting needles and other objects where they need to go with interventional fluoroscopy. So we use that to guide what we do. And we're really good at that. In fact, we learned during the mild procedure, we were better at that than most of the surgeons, because most of my surgeons just didn't have the confidence to do mild, because they would just rather open up and look at the ligament, whereas we would go in through a little tubule. So we have those skills, and where we really need more work usually is surgical approach, wound closure, all those things are important. Now, you could argue about sagittal balance. We'll get to that in a moment. Larry Khateeb, my good friend, the neurosurgeon, points out that what I do is going to cause a lot less issues with sagittal balance than most large surgical procedures. But then we have surgeons who, everybody gets a big surgery, everybody gets a fusion. That's how they were trained. And I've spoken at some major spine conferences where I've been the token interventional spine pain person, and they'll go through, what would you do in this case? And then we're going to do the third or fourth instrumentation fusion. And I'll say, what about neuromodulation, for example? Because sometimes more surgery doesn't make you better. So you got the two ends. You got some pain doctors that everybody needs a procedure that they do, and some neurosurgeons, ortho, that everybody needs that. There's this middle ground. This is what's confusing, and this is what confuses patients. There's a middle ground where we have really trained ourselves and other folks to do things very safely and very selectively, where we go in and do a posterior SI joint fusion, for example, which we've done several hundred of those with no adverse outcomes to date in our practice. That doesn't mean we couldn't get one tomorrow. That's been very successful, for example. But we have a very strict selection criteria. We have very good perioperative care, and we have good preoperative preparation of the patient. We also do a lot of things like BVN and SCS and DRG, and all these things we do that really are based on finesse. I always tell young residents and fellows who rotate with me, it's not a muscle procedure, it's a finesse procedure, almost everything I do. So with that in mind, we also have surgeons who do less invasive things when appropriate, and that's a growing group, particularly some of the younger physicians that I work with. And some of the older physicians I work with are really saying, okay, this person doesn't need the bigger surgery. They need something in between or smaller. And they either learn to do it themselves. For example, there's a few surgeons in West Virginia who've learned to do posterior lateral arthrodesis, have learned to do MAUD, have learned to do the posterior approach to SI fusion. But most of them will send those patients to see me or one of my partners. But they've actually came to that point. So that middle ground, the best person to do it is really the person who has the best training in that approach in that community. And it may be me, and it may be the surgeon. It kind of depends on the procedure itself. So I think it's evolving, but one thing's for sure, the minimally invasive method is going to win. I think we've already won that battle. No one wants the larger surgery unless it's needed. And so we're both going this direction. And I think in the future, it probably won't matter who does it, it's their outcomes. And right now, I think in my region, most of the minimally invasive things are done by someone like me. In certain areas of the country, it's done by a progressive neurosurgeon or orthopedic spine surgeon who offers those therapies, like Jeff Hinn, for example, down in Florida, doing a lot of minimally invasive spine surgeries. John Urfanos in West Virginia, minimally invasive spine surgery. Larry Khateeb has a spine center in Los Angeles for minimally invasive spine. So there are a lot of people going to that in neurosurgery and orthopedic spine and doing a great job. But I think it comes down, more importantly, the argument is, in those political battles, I try to stay in the middle ground there. And we've been successful doing that. So there's a lot of surgeons who don't want us to do anything. There's a lot of pain doctors who want to do everything. And both are wrong. We shouldn't be doing everything. We shouldn't go outside of our scope to things we shouldn't be able to do. But also the surgeons are wrong who don't want us to do anything, because we're going to be better than they are at many of those procedures. So for a patient who asks the question, do they need the minimally invasive procedure? Is that what they need? That's the first question they have to ask. Do I need that, or do I really need that bigger surgery and I'm healthy enough to have it? Well, if you really need the bigger surgery and you're healthy enough to have it, you probably should go have it. I mean, that's just where we are. But if you need the smaller surgery and it's appropriate for you, then the question is then who in your area, and a lot of people do travel. I get a lot of patients from out of the state, even out of the country, but who can you see that has the most training in the approach? Or if it's a new approach, whose skill sets matches the new approach? And one example that you can use where we both match it is two procedures. Mainstay, who does the reactivate, both interventional pain and spine surgery match that procedure. We both are good at that procedure. So as a patient, I don't think it would matter who did it as long as they are competent. BVN ablation, we're both competent at that procedure. I don't think it matters who does that as long as they're well trained. SI fusion, the argument comes, do you want to do a lateral approach, a lateral oblique approach, or posterior approach? Well, it's really evolving where most pain physicians can do any of the three well. Most surgeons only do the lateral approach. it's a very different approach. You can argue which is better, you can argue which is safer, which is more effective, but it's very different. So if you're in a community where you want lateral oblique or posterior, you probably have to go see a pain physician. If you want lateral approach, you probably can see someone like me or one of the surgeons. We both do that approach as well. And we base the selection on the patient's anatomy, things of that nature, to decide which one is more appropriate. That's a long answer, Omar, but that's a complex question, and it's still evolving. But I think within 5 years, it's going to be pretty clear. Most people will need a minimally invasive procedure. Who does it will probably be both groups. The ones who are extreme, everyone needs a big surgery, extreme, the pain doctor can do everything. I think those people are going to get pushed out into the wastelands because they're going to be outside the community. I think our community is going to come together and do what's right for patients. I'm an optimist. So I think we're going to go to the best thing for patients, regardless of specialty, and we're going to make sure the training programs get better. And that's what I think is my focus is going to be the next 5 years, is that mentoring training part to make it better for patients.
Yeah, and I appreciate you explaining that, because a lot of myself and my peers have seen this, and we just didn't know what to make of it. And it makes complete sense. I think that as you have an evolution of medicine and healthcare, these things happen. I mean, there's a period, my father's a general surgeon. There's a period that general surgeons were doing everything, but then little by little, certain specialties like urologists were just better suited for certain procedures. That's just the nature of these things. The fact that like neurosurgeons have to have an orthopedic surgeon a long time, I had no idea that was the case, right? And so I think it's a natural evolution of medicine and healthcare. And I think this is also going to lend itself to the evolution of training. How, you were one of the founders of Aspen. I'm wondering, how important is it? It feels like it's more important than ever today that the level of education and continuing education you use both online and in person as a physician today, just because of how things are evolving. But I've noticed that at least in certain specialties, it seems like people are not going to the massive conferences anymore. They're trying to go to more specific, smaller, specialty-focused conferences. What's your advice to, let's say, the fellows who are coming out of training and starting their practice? How should they think about continuing education? Because there's only so many hours of the year that you can dedicate to it, but you have to do it.
Yeah, it's a good debate. And I think when you and I first talked, it was based on one of my posts that I said, we really aren't doing a very good job of training people in a lot of areas. And I think that's true. And I think I see that as an opportunity, not as a defeat. So if you think about this, if you go to a fellowship program and you have 1 year, and there's a big debate now, should it be 2 years? Well, I don't think it should be 2 years. I think I think it should be more. I signed the paper for the article that said that, but I didn't mean it the way that it was meant. So 2 years of fellowship with the same people, if they didn't teach you much in the first year, they're not going to teach you any more in the second year, because they're teaching the same thing. So if you didn't learn any new methods in that first year, additional year in that same program will do you no good. You'll be as good as you are in whatever they normally do. So during that, you asked about CME. A good example is, one of the reasons Aspen's grown so much, and I think, we're the largest interventional spine procedure in the society in the world now, I believe, by membership. We've grown so much because fellows do come and they get exhibition labs where they get to watch experts do the procedure they want to learn. And then they decide, okay, I didn't see that in my fellowship, and I'm not going to see any in my fellowship, because if we train them with a cadaver and they go back to their fellowship and never see the procedure again, it really wasn't worthwhile. They see all the things that are out there. So every new technique that gets FDA approval, we're going to have it in that lab with neurosurgeons, orthospine, and interventional pain teaching in the labs. And then they say, I really want to learn that. Then they can select a more immersive course where they go and spend, as you mentioned, at a smaller setting to learn that technique. For example, we had a DRG lab there 2 years ago. And so they were able to come and do DRG for a few days, just all day long, to get really critical hours. I do think that where we want to go, and I started a task force on this, with several folks, PMR, anesthesia, orthopedic surgery. We're looking at, I think the solution might be a year of a hybrid approach of mentoring. And what I mean by that is, if you trained at a program that wasn't very interventional, and you were told, a lot of times fellows are told it's going to be very interventional. They get there and they say, we're not doing anything modern. Well, if that happens to you, but you get good basic skills, I want to create a program where they can join a fellowship program after their fellowship, if you will, where they come and they finish the fellowship, they're board eligible, they may have good basic skills. They can come and take a job where they spend 2 or 3 days a week seeing their own patients, having their own practice. But then the other 2 days a week, they scrub in with people that do these newer techniques. and they actually get hands-on training for a whole year in that hybrid role. So they're making more money than a fellow would make. For example, they may have double or triple the salary of a fellow because they are producing revenue on those other 3 days, and so they can be paid more. But the other 2 days, they're an apprentice. They're really learning not just the method, but also the selection, also the postoperative management, also complications mitigation. So that's where I think we should go. I think we need an apprenticeship that's a hybrid approach after the fellowship, where they actually can make a living that's relatively decent, where they can feel like they've been rewarded for their fellowship. And if, and we have a lot of people do it right now. If you go join certain practices in America, you're getting all that training. And a lot of people spend a year or two with me or someone else, and they go out on their own, or Doug Bill or someone like that. But I think we should formalize it. And then when they leave that program, their hands-on skill, and they might stay there and become an attending and stay there the rest of their career, but then their skills will be much safer. And I think we'll improve patient safety that way. So that's what I envision. And I think, I'm sure other societies like NAS, who does a great job, and others will have the same goals. North American Neuromodulation Society, NANS, for neuromodulation. But Aspen's going to be one of the people wanting to lead that rally to improve care. But it can't be during fellowship. It can't be extended any longer, in my opinion. And it's got to be in only candidates who really have the desire to do it. And some people won't have that desire. So that's, I see the apprenticeship hybrid solution as the solution. Stay tuned, Omar. I'm hoping within about 24 months, we'll have that up and ready to roll, because it will be a process, and it'll be political, and it'll be people, kicking and screaming. But at the end of the day, I think this is going to be the solution for us. And then you'll be an Aspen apprentice scholar or something like that. We'll have some kind of classification for you. And then I think that will help you with credentialing. I think it will help you with having just better overall outcomes and happier patients.
And fantastic. Yeah. And I'm excited to see that. I have a little bit of a curveball to throw you, and just because this is rather new, one thing that happened, I don't know, I feel like COVID kind of contributed to this, where because of the state of things from COVID and everything, the general public took a much higher degree of interest in their health, right? So as a result of it, a lot of money got poured and just shoveled into like health tech, longevity, et cetera. You and I both talked about this before we came on the show. So one of the people who is kind of, sort of the face and proliferates a lot of like information on this, and controversial or not, is Brian Johnson, who is the founder of Venmo. Braintree sold it, I think, for $900 million, and now he spends about $2 million a year reversing his age. He's very successful about it. He invests in medical devices, et cetera, posts a lot of this stuff online. For those who are watching on Spotify and YouTube, you'll be able to see this. For those who are not on other platforms, I'm going to describe what we're seeing here. But I have a tweet that he just posted earlier this week. And I'm just wondering from your perspective, if you can kind of comment and give your thoughts behind this. Let me know when you can see can you see the screen?
I do.
Perfect. So we have Brian Johnson laying on his side, looks like with some ultrasound and something being injected in him. And the thing, and just to kind of point this out, this post got 1.4 million views. So people are becoming more aware of this. What was being done essentially is that he put that last week, I had 300 million bone marrow derived mesenchymal stem cells injected into 6 joints over 2 days, knees, shoulders, hips, as part of a clinical trial in the Bahamas. May repeat this therapy as needed. What's your thoughts when it comes to stuff like this? Patients are, going to see this. I'm wondering, is this a potential avenue that we can see some innovation in? I'm wondering, what's your take on all this?
Wow. So yeah, that is a curveball, but let's talk about it. I actually heard him on the
I know you can handle it. So I was like, let me just bring it up, and see what your thoughts are. Might as well answer it on this show,
Yeah, no, I love it. So I heard him on a podcast recently, and he's very controversial, as you know. And he's got a lot of haters, but all people that do things have haters. So that's just the way it goes. So I understand. But, if you listen to Joe Rogan, for example, a lot of MMA fighters go down to Guadalajara and they get injections of stem cells in their cervical spine and their shoulders and everything else. And then they tell them not to do anything for 12 weeks. And then they say, oh, it really helped me. Well, they didn't do anything for 12 weeks. It probably didn't help them at all. They probably rested for 12 weeks. I do think this is an area of excitement and an area of great danger. And recently I heard of a young woman who was 18 who had stem cells injected in her cervical spine, and he hit the cord and She's now an 18-year-old quadriplegic. And so, this sounds like it's pretty low risk. This is really high risk. And the reason the studies are in the Bahamas and Guadalajara and everywhere else is because the FDA would never approve this in the U.S. without more data. We're getting ready to do a stem cell study in the U.S. in the disc that's through the FDA approval. And I think if you're a patient seeing these things, and you're not a $900 million exit person, and you're really thinking about your health care, and I think, again, longevity should be something we bring into all of our pain patients' lives and try to help them because it helps their pain as well. But you have to be really careful with a lot of these things. If you go to Guadalajara and get 7 joints injected with stem cells that you have no clue where they came from, I think your risk of getting some stem cell that comes into a cancer, gets into an infection, causes nerve damage or other problems is quite high. So for me, I think that we need innovation in the area of regenerative medicine. But again, it's an area of abuse. A lot of people abuse patients in this area. They promise them things, they pay cash for what they're getting. And really it's, almost like magnetism back in the 1800s. It's quite, a lot of it's quite quackery. There are some really legitimate people out there who do a wonderful job, and they're studying things in a scientific fashion. Remember, right now, none of this is approved by the FDA. None of this has been studied in large populations,
and still quite experimental. I mean, there might be people who get good results, but it is still technically experimental because it's not being regulated.
Well, absolutely. So I have a lot of friends that are in their 20s and 30s, and so they'll listen to some athlete go down and get multiple injections of stem cells, and now they get an injury and they want to go do that. Well, who ever regulated that clinic in Guadalajara, for example? No one. Who's looking over that? So I am worried about people getting, number one, taking advantage of its safety. So I think that we should look at this with great interest. We should see that as a great opportunity of advancement, but we should see this in research centers where they actually have controls and they can monitor adverse outcomes, both short term, but look at 5-year data. Did that person have more cancers than other people, for example? Because I'm afraid the answer is going to be yes. So to me, it's going to be a great therapy in certain populations, but it will be based on proper scientific harvesting of cells, wherever they get the cells from, proper preparation of cells, and then proper use of cells for the right indication. Because quite frankly, a lot of the studies that I've seen have been negative when done properly, that they haven't worked. And these are cash pay, so these are, sometimes people will spend a lot of their life savings to have something done because they're desperate. And guess what? After 3 months, they're back to where they were. That can happen with something that's FDA approved as well, but I think at least we know the odds in those devices. So yeah, that was a great picture of that buttock injection. It reminded me of testosterone pellets people get as well. But I am a little leery of this, and I would encourage people not to do it unless you've really looked at the science behind what you're doing, because we've seen some real disasters out there so far.
Yeah, and I think, what's good, I think it's good that the general public has an interest now in their healthcare and everything. But I always recommend people like, hey, whatever you read online, even myself, look, I went to medical school. I have a father who's a surgeon, so I'm able to read these things at a much higher level. Even so, even something as small as, I'll give you sort of personal, great example. I wanted to raise my testosterone. So, I looked at Tongat Ali and Fedosha, right? But before I took it, I went and had a conversation with my primary care who's knowledgeable about these things. And I said, hey, I'm thinking about taking these supplements. What are your thoughts? And that's with the supplement. So I always recommend people, especially the listeners of the show, do your research. It's okay to get interested in these things, but go have a conversation with your doctor, first before making these kind of decisions, and again, a quick plug for you, for those who are interested to, sort of learn more on the pain side, you have a great podcast called the Pain Unfiltered Podcast, right? So for those who are interested, go check that out. And Dr. Deere, again, I really appreciate you spending some time with us. As we kind of round things out, I want to talk about Aspen 2024. So for those who are interested, Aspen 2024 is happening in Miami, July 11th to 14th. If you're interested in it, I recommend go to ASPN Pain, that's PAIN, ASPNpain.com. You'll be able to learn more there. What are you most excited about in terms of some of the sessions? I know you guys haven't released the agenda quite yet, but give us a little bit of a sneak peek. Like, what are some sessions you're personally excited about? I know you love all your sessions, but which ones come to mind?
I think the agenda's out, actually. So I think.
Oh, it is? Okay.
We'll check that. We can put it in the notes potentially. No, so we created, I'm just going back to your last question on this, what excites me. We created a longevity committee this year, and people ask me, why are you doing this to a pain society, an interventional spine society? And we have some great people leading that panel and leading that component of our society. because we really feel like if pain patients who have spine disorders get where they can actually get a certain amount of exercise per day, if they can get where they can do some strength training, if they get where they can actually improve their diet, get where they can actually have proper weight, get where their sleep improves. A lot of our new studies, we're looking at sleep outcomes, which is, people say, why are you looking at Pittsburgh sleep studies? Well, because it's been shown to improve your longevity, but also to improve your quality of life. So I think the longevity panel and session is going to be very interesting. I think we're going to see a lot of really great discussion there. We have some sessions on who should be doing what in the interventional spine. So we have some sessions with ortho spine, neurosurgery, and anesthesiology and radiology, discussing exactly what you asked us today. And we'll hear it right from the, physicians themselves. I think I should be doing this and you shouldn't, and vice versa. So we'll hear some very, very friendly arguments about that. And I'm sure we'll hear opinions that are usually what we find is when you get like-minded people who are pretty smart together, they come to a pretty common ground, but that'll be very interesting. I think the other part I'm really looking forward to, we have a panel with a lot of young men and women that are really just in the first 3 years out of fellowship. And they're going to talk about what they've seen so far in the mentoring and learning these new methods. So some of the questions you've asked me today, Omar, is going to be exactly what we're going to cover there. There's a 5K run in the middle of the heat at 5 p.m. on Friday for charity. We're raising money for two charities now. One is the Ironman Foundation, looking at really helping first responders around the country. And the other is going to be a foundation working for the Navy SEALs who've perished in battle and some of their family members. So we're going to be looking at raising money for one of those charities as well. So I think that's always a highlight for me, because we're actually getting out there, getting fit, and suffering in the heat a little bit. And at the same time, we're helping people. So that's always a highlight. And then lastly, we're going to have a lot of CEOs there for different companies. And we always have a non-CME CEO panel where we actually get the CEOs together and ask them what they think is interesting. And sometimes they're friendly to each other, and sometimes they get a little salty with each other because they're competitors. And I enjoy both the friendliness and the saltiness there, because I think that's what we're here for, to see that competitive spirit drive innovation. And I'm really looking forward to that. So that's just a snapshot of some of the things I'm looking forward to. There's a lot more, as you pointed out. You have to love all your children, not just one or two, and every part of that I love. But those are things that I think will be very interesting for those who attend.
Fantastic. No, and I love that, and especially the forum of, having radiologists, spine surgeons, and having these kind of discussions. What I love most, and again, you're a great example of that, is, as a physician, like I'll use my father as an example. He's 78 now. In my father's time, it was very much just like, hey, I'm going to just practice medicine. All this other stuff, I'm not going to worry about it. I'm just going to practice medicine and the business will take care of itself. And those times have changed. So as a physician, as a clinician, you have to spend time being out in the marketplace, on social media, having these discussions and everything, because if you don't control that narrative, somebody else will. So I just want to, commend you and the people at Aspen for doing these kind of things, because it's not easy. It takes extra work to put this stuff together, but the fact that you're doing it, plus finding ways to give back to charity, I really think is commendable. I love. And again, before I even knew of you, I heard about Aspen and how much people loved attending it. And I always hear it, like, oh, Omar, you got to go to Aspen. So hopefully I can make that this year. As we round out last part of this interview, and again, you're a friend now of the show, so I want to have you back on for future topics. I always like to do sort of rapid fire questions. This is kind of just some fun stuff. You can take as long as you want to answer these questions. So we'll do 2 or 3. You ready?
I'm ready.
All right. So you mentioned, you and I, we have this mutual love of the area of longevity and optimizing our bodies and health and everything. What are some of your favorite, most recommended longevity practices? This could be a habit that you recommend people pick up. It could be supplementation, exercise, etc. When you think of the average person and they're like, hey, Dr. Deer, I want to I want to optimize for longevity. What are some things that you recommend first?
Well, if you look at the data, and there is some data out there, Mark Hyman, people like that, Peter Tea, I think it's like anything else. If you go and have the same dinner every night, you're going to get bored with the food, right? So I think the mixture of sports, for example, I joined Ironman Hawaii later this year and Ironman New Zealand. And so every week I'll swim 2 or 3 days a week. I'll run 5 days a week. I'll bike 3 days a week. But also I add in strength training, because strength training has been shown to improve longevity. And if you fall and you can catch yourself, for example, or you can grab a rail, when you're 70 years old or 80 years old, your chance of living longer, it sounds kind of crazy, but strength training can make you live longer because you don't fall as hard. You don't fall as awkwardly. So strength training is very important. Endurance sports, it takes at least probably 180 minutes a week of endurance of some type to really improve your overall health and benefit you. Now, there's some debate. If you get more than 12 hours a week of endurance training, it may hurt you. That's still a question. So 3 hours a week is great. 12 hours a week is maybe the limit. Some weeks I do 20 hours a week of endurance training. So I'm not sure I believe the 12 hours. I guess we'll find out down the road. And then sleep. One thing I added to my regimen recently, I didn't last night because my plane was canceled out of LaGuardia and I drove all night. So I'm a little tired today. But one thing I have added to my regimen too is sleep. I used to sleep about 4 hours a night and I felt fine. I would go to bed about midnight, get up about 4. And now I sleep anywhere from 7 to 8 hours a night, a lot of nights. And I really think that, I did that because if you look at the telomere damage you do from lack of sleep, it's pretty significant. So I do think that sleep is something I've added in personally, trying to get at least 6 hours every night. And I think a lot of people brag about their lack of sleep. I think I used to, but now I really think that you need to add sleep. And then lastly, you asked some things that I like to do is recovery. I used to overtrain and I went without a coach last year and I got rhabdomyolysis in an ultra run and almost went to kidney failure and was in pretty bad shape. And I did that because I overtrained. So I'm back to my coach, Matt Dixon now, who's out in San Francisco. And one thing that he always focuses on is some recovery. So you give yourself time to get some rest. It can't be all about training. And then the other thing that's been shown to really improve people's lives is their social life. You have to have a social life. And people who don't have a social life don't do really well. And we see that in our pain patients all the time. I think one of the reasons I had a lady today when I walked in the room, she came over and hugged me. She had a great outcome from a procedure we did about 3 months ago. And she's back to church. She's going to Kroger's. She's doing things. And I don't know if it's the pain relief she's so happy about or the fact that she's back to a social environment. She went to her book club this weekend, she said. That's really important for longevity, but also for pain patients to get back engaged in society. So those are some of the things that I see as keys that I've personally learned for both myself and several of my colleagues.
I love that. And, I completely agree. I think one of the reasons why I got a Whoop band is just to monitor my sleep. But again, I love this. And I hope I see more clinicians like you. And I think you're setting a great example for younger clinicians, which is, I think as a doctor, you have to live and breathe health, like me personally, I can't take a physician seriously if they don't have their own health in check. If they have bad habits like smoking, if they're overweight, all these things, it's very hard for me to take their clinical advice seriously when I'm like, well, you have to be a walking example of that, right? Not everybody can do an Ironman, by the way, but just like some basic health parameters I think are important. So really, really good tips. Next one is, you're in your library, I'm in my library. Continuing education is a big part of professional growth as a clinician. Doesn't have to be clinical, but what's a book you feel like you often gift or recommend to people most often?
Well, I think if you think about what type of gift you can give recently, I'm going to tell you a gift I got recently, not one that I gave because I give. It kind of depends on the person. I give religious books to some people. I give clinical books to some people, and I do think it's a great way to gift people. And, I do a lot of reading while I run. So my friends say, you're not really reading, you're listening to audiobooks, but, I get exposed to a lot of books that way. And, and like some of them are biographies, like Steve Jobs' biography, for example, is a phenomenal thing to learn about a person's good and bad traits. But recently a resident gave me a book and it was about a doctor in California who was a neurosurgery resident who developed a tumor and he was dying. And you may have read this book, but he actually wrote about his death as he died. And I posted that on Twitter and said, I think everyone should read this as a physician because, you got to see people, the mindset like I may have, and then you got to see that same person being the patient and that same person being the husband, that same person being the child, because you saw all those perspectives. So to me, that's been a great gift that someone gave me recently. So I think the key there is to match whatever you recommend to the person's, maybe their deficits. And I had a deficit of really understanding, I think, what some of the patients go through, and reading that book really reminded me a lot of those things. And so to me, that was a great gift. So Marco, if you're listening to this, I appreciate that. Very much appreciated.
What was the name of the book, by the way?
Oh, I knew you were going to ask me that. I think it's something about breathe. He develops cancer in his lung. You can look it up maybe there as we go. I wish I had Joe Rogan has the guy that looks up stuff.
I know. I need to have my own Jamie for this.
It's not breathe. It's like the breath you breathe. I believe may have been the name of it, but it was a young neurosurgeon.
Oh, yes, I found it. I found it on your Twitter. It's called Yes, I heard about this, but I haven't read it yet. It's called When Breath Becomes Air by Paul Kalanithi.
Yeah. So that book, that's the name of it. Yeah, that book I just received a few months ago, and it didn't look that great to me. God dies, looks depressing. So I get on a plane. I'm flying out, and I read the book from one side of the country to the other, and then reading the whole book as I flew across the country. And by the time I got to the other side of the country, I was crying my eyes out. So the person beside me probably thought I was crazy, but I enjoyed it. So that's the type of book I think I'm going to start to give in the future, because that impacted me. But I have a lot of books there. I have a lot of interest. I have a lot of interest in warfare and what we learn from battles, and biographies of great people, and so I think it really depends on the mood and the person.
No, absolutely. Look, Dr. Deere, I want to be mindful of your time. Thank you so much for coming on the show. Really appreciate it. For those listeners who are listening in the car or following, go give Dr. Deere a follow. He's on LinkedIn. So Tim Deere, Deere spelled DEER, on Twitter at Doc, DOCT Deere, DEER. Give him a follow. And that being said, for those who are in the industry space, please go give Aspen a check. Make sure that you're sponsoring. If not attending, that's aspnpain.com. I'm your host, Omar Khateeb. It's been another episode of the State of MedTech. If you haven't already subscribed to the show, give the show 5 stars, and we'll see you all next time. Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this episode helped you, send this to somebody who'd really enjoy and appreciate it. Share and spread the love. We'll see you all next time.